Hello, Dr. Olson and my fellow classmates. My name is Sheeba. My clinic site is Heights Family Practice in Pearland, Texas. Last week I had an interesting case, so let me present her. Um, Let me begin with her identifying data. This is Miss Amelia Saxido. She is a Hispanic origin female, 42-year-old female who came to the clinic for the excessive tiredness and follow-up on her lab works. She's a reliable historian. She was in our clinic last week with the same reason, and we did all the lab works. And patient insists us to do all the lab works too. Chief complaint: I'm here for the follow-up on my lab works and excessive tiredness. HPI, this is Miss Amelia. She's a 42-year-old female who came to our clinic with a complaining of excessive tiredness, and also she does have a lump on her sternal area past 1.5 months, and she denies any fever, cough, shortness of breath, chest pain, or any congestion, and also any recent travel history. But she did travel to her country. She is originally from South America. She traveled 1.5 years ago to visit her family, along with her family, but she is the only one and in there she diagnosed with brucellosis and treated with antibiotic. She was the only one who got sick at that time. She also complains of muscle aches, and the pain she graded as 5 out of 10, and it is intermittent. And mainly she complains of pain on her lower extremities. Past medical history: other than brucellosis in 2019, she doesn't have any other past medical history. Past surgical history: hernia repair in 2010 and C-section ×1 in 2008. She is up to date on her dental and eye exam. She does not have any depression. She is not allergic to any medication or any environmental allergies. Other than multivitamin, she is not on any other medication, or her immunization status are up to date, but she is not taking any. She refused for the influenza vaccine. Her family history: her both parents are still alive. Dad is diabetic and mom had history of arthritis and hypertension. Both maternal and paternal grandparents are no more, and she doesn't know the reason for their death. And she does have 4 siblings: one sister and 3 brothers. Uh, one brother and one sister is diabetic. Rest of the whole family and the siblings are healthy. She does chemical history: she does not use any smoking, no illicit drugs, or occasional alcohol intake that she used, wine 8 to 12 ounce, and no secondhand smoking either. Social history: she is married and living with her spouse and 2 kids. She owns a housekeeping company, and she does have some stress issues because of her work, but her family is very helpful. Sexual history: she is sexually active with one partner. She uses IUD for the prevention of pregnancy. Hobbies: she likes to cook, stitching, and some artwork. Sleep: minimum 6 to 8 hours of sleep if she does get it, and no special diet she follows. She tries to eat as much as from the homemade foods. She's a Christian Catholic. She does not have any special religious preferences. Review system: general patient reports excessive tiredness, but does not have any recent weight loss or anything. And heat is okay. Respiratory wise, she reports a lump. She does not have any wheezing, tight chestness, productive cough, or any short of breath or anything. But in her anterior sternal area, we can see there is a lump protrude outside, or about 1 centimeter, but it doesn't bother her with her deep breathing problems. And musculoskeletal, she reports pain especially on bilateral lower extremities, muscle pain. And GI wise, she reports also loss of appetite, but denies any abdominal pain, nausea, vomiting, diarrhea, anything. Let's move on to objective data. Let's start with the vitals. Her vitals are stable, no fever, 97.6 degree Fahrenheit, pulse rate is 66, blood pressure is a little bit low side, but she runs low. That's her norm, 97 over 64, respiration 19, SpO2 99. She has pain 5 out of 10. Her weight pretty much same. Her BMI is 25.4. And general appearance, she looks so normal appearance, and apart from mild to moderate weakness, otherwise she looks normal. Hint is normal. Pulmonary on inspection, no shorter of she is not using any accessory muscles, and lung sounds are clear. Anterior and posterior bilaterally, no bony crepitus, and there is a small lump which I already mentioned. And GI wise, no tenderness or distension, and bowel sounds are normal on all quadrants. Musculoskeletal, symmetrical and normal gait. Active and passive range of motion was normal. Mild tenderness present on bilateral lower extremities on palpation. No neck pain, no LBP or joint pain, lower back pain or joint pain. Integumentary on inspection, there is a 1 centimeter hard lump node knotted in between the anterior mediastinal wall. No tenderness on palpation. The assessment, differential diagnosis, number 1 is brucellosis, number 2, COVID-19, and number 3 is fibromyalgia. The reason brucellosis is very rare in US. The occurrence of cases are minimum 140 cases annually. It is caused by a bacterium called Brucella. These bacteria can affect both human and animals. People get this disease from eating contaminated food and pasteurized milk, and also infected animal, or also through the raw meat. And the minimum human to human transmission of disease is very minimal. It can be treated with antibiotics. COVID-19, I consider this because COVID has different symptoms, and she came in with severe tiredness, and that's the reason I consider COVID. Because it's like allergy, sometimes symptoms similar to respiratory conditions like allergies and flu. And the next one is fibromyalgia, because patient was complaining of lower muscle aches. So fibromyalgia, again, it's a chronic disease condition. There are no special diagnostic tests to rule out this condition. As a result, fibromyalgia can misdiagnose most of the time. Symptoms include consistent muscle pain, tenderness, fatigue, sleep, and cognitive disturbances. The plan for this patient is I'm trying to finalize this case with brucellosis, because patient had a history of brucellosis in 2019, and also it can reoccur at some point in your life, and if they didn't get enough treatment. Based on the interview and objective assessment and history of brucellosis, and plus this patient was here last week and insisting us to do the lab work, and her brucella IgG and IgM came positive for brucellosis. And that's the reason brucellosis is considering as the priority diagnosis over the other two. The diagnostic exclusion for the COVID-19, the COVID-19 PCR, we did it and it was negative. And the rationale not to include fibromyalgia is because patient does not have consistent dull ache, and also it is a chronic disease condition. We referred her to a dermatologist because of the anterior chest wall lump. And the medication for the brucellosis, we suggested her to take doxycycline 100 mg POBID for 6 weeks with no refill, and rifampicin 600 mg POQ daily for the next 6 weeks with no refill too. Alternative treatment which we can consider for this patient is in uncomplicated brucellosis, doxycycline with aminoglycoside combination we can try, and also doxy with cotrimoxazole is another choice. But monotherapy or short-term therapy is not effective for the brucellosis. At least minimum a continuous dose of 6 weeks antibiotic is effective for the treatment. Follow up after 6 weeks. We ask the patient to come back to the clinic after 6 weeks of antibiotic completion. Diagnostic test, history and physical, CBC, CMP, because patient was complaining of tiredness, so we just want to rule out whether she has anemia or anything, or any other issues, and A1C, because another reason to rule out diabetic, sometimes that also can get chronic tiredness. Vitamin D deficiency also leads increased fatigue. COVID PCR to detect whether patient has coronavirus, and Brucella antibody, especially IgG and IgM, with referral to agglutination. In acute brucellosis, the presence of Brucella specific IgM within 7 days of infection, and Brucella specific IgG will be present after the second week. Both IgG and IgM will decline after a couple of months, but presence of high IgG with declining or absent of IgM signifies the chronic infection or relapse of the disease condition. Education, we advise her to the patient to avoid consuming raw meat or undercooked meat or meat products. Encourage the patient to avoid consuming unpasteurized milk or milk products. In US is very very rarely, but when she traveled in her country, probably she consumed any one of these. I'm assuming maybe that's the reason she probably got the disease. And also we encourage the patient to wear protective gloves and glasses if she is handling any animals or animal tissues. Instruct the patient to cover any open wounds when coming in contacting with any animals. Regularly wash hands. That's the main mode of transmission of any kind of disease. And also encourage the patient to complete the full course of antibiotic. The holistic approach which I used in here is, as a provider, only medical knowledge is not enough. I realized that I need to have a loving heart towards my patient to maintain a therapeutic relationship. That's one of the Gene Watson's criteria of therapeutic approach. In this scenario, I developed a sustaining, loving, and trusting, caring relationship with my patient, maintained a genuine teaching, learning experience, and a caring, healing environment for the patient and her family. And teaching is not just the transfer of knowledge, but a heart-to-heart dialogue connection. So that's from one of the Watson's criteria, holistic approach criteria. Here ends my case study. Thank you.